Hello, I'm Donna Cryer. I am the founder and CEO of the Global Liver Institute, and I am so proud to be the convener of International NASH Day. In 2023, we have an incredible opportunity to step up for NASH, to be there for NASH patients around the world. I think we have a particular opportunity, as you'll hear from our panel, to talk about leveling the playing field, ensuring access to NASH treatments in Black communities. We have an even larger opportunity as we build the field of NASH together to build the field with equity from the start. And so to talk about how we do that, I have with me the best possible person for it. I have Dr. Ratanya Carr, who is, I could read her titles all day long, but she is the Cyrus E. Rubin Chair in Medicine and Division Head in Gastroenterology at the University of Washington. She is a hepatologist and co-founder and board member of the Association of Black Gastroenterologists and Hepatologists, a dear, dear ally of the Global Liver Institute. And she'll be moderating this session, Leveling the Playing Field. Dr. Carr.
Thank you so much, Donna. It's always a pleasure to be here with GLI each year to bring awareness to NASH and comorbid conditions. And I am really honored to represent the Association of Black Gastroenterologists and Hepatologists again this year, or ABGH. Next slide, please. ABGH is a 501c3 organization whose mission is to promote health equity in Black communities, advance science, and develop the careers of Black gastroenterologists, hepatologists, and scientists. And today we are here to have a conversation about health equity for Black patients with NASH. And we're specifically going to be talking about therapeutics for NASH and NASH comorbid conditions. And so we ensure to get all of this information out as far and as wide as possible. At the end of this, we'll also share this information on our platforms, on our website, as well as social media sites, as well as the GLI website. So let's get started. Next slide, please. I'm excited to introduce to you our panelists for today. You will hear from our fierce patient advocate, Mrs. Victoria Arce, who is also a patient with NASH, and she is the independent provider for the mentally disabled. Welcome to you, Mrs. Arce, and thank you so much for joining us. You'll also hear from Dr. Nadej Gunn, who is a gastroenterologist and hepatologist. She is a certified principal investigator by the Association of Clinical Research Professionals. She's also a U.S. Air Force veteran. Thank you so much always for your service. She's the adjunct assistant professor at Texas A&M School of Medicine and the medical director and president of Impact Research Institute. Dr. Octavia Pickett-Blakely is also a gastroenterologist who is at the University of Pennsylvania. She's an associate professor of clinical medicine and the director for the Penn Center for GI Nutrition. Dr. Pickett-Blakely leads clinical research on nutritional diseases. Welcome to you. Dr. Rakesha Wilson is a general and bariatric surgeon at the Cleveland Clinic in Ohio, and she manages individuals who have NASH and obesity. Dr. Wilson performs collaborative, clinical, and translational research. Thank you for joining us. And finally, we have Dr. Julius Wilder, who is a transplant hepatologist and assistant professor at the Duke School of Medicine. He is nationally recognized for his work in health disparities, health equity, and social drivers of health in gastroenterology and hepatology. He's chair for the Duke Department of Medicine Diversity, Equity, Inclusion, and Anti-Racism Committee, and vice chief of Diversity, Equity, and Inclusion for the Duke Division of Gastroenterology. Welcome again to all of you, and thanks so much for joining us in this important conversation. I think I'm going to start with you, Dr. Gunn, today. You are a clinical hepatologist, and you're also running your own research institute, leading clinical trials. I'd like you to set the stage for all who are watching. Remember, we're really focused on the community who will be listening to this video today so that we make sure to get the word out about this condition and what the options are for them. So can you just start by telling everyone what exactly is NASH?
Thank you, Dr. Carr, for the opportunity. Can we kindly advance a slide, please? So NASH, as you know, stands for non-alcoholic steatohepatitis, and it is part of or under the umbrella of non-alcoholic fatty liver disease. NASH is the angry form of fatty liver disease. So once the fat cells inundate the liver then progresses to inflammation, irritation, and ultimately scar tissue. And that scar tissue can progress to cirrhosis. We know that NASH is implicated by risk factors such as diabetes, being overweight, obese, high blood pressure, and high cholesterol. And it really is a condition that is leading the gamut in our world. We know that over 100 million people in the United States are affected with fatty liver and NASH, and that number is only going to grow. Currently, we do not have any treatments that are liver specific to treat fatty liver or NASH. We do want to help solve the issue of managing the underlying risk factors like the diabetes, the obesity, the high blood pressure, and high cholesterol. And currently that is the best we can do. So when we talk about lifestyle modification, we are encouraging weight loss. Anywhere around 3 to 5% will really start to get the fat out of the liver. But when we get that up to about a 10%, 7% weight loss, we can start seeing the NASH actually improve and some of the fibrosis turn around. Medications are definitely in the cascade of, or in the types of things that we do try to use to manage fatty liver disease. Again, we don't have anything specifically approved, but if we can treat the diabetes, the blood pressure, the cholesterol, that all is very helpful. There are a couple of medications like antioxidants like vitamin E or medications that are specific for diabetes that can help change the fatty liver paradigm. And surgery is also something that we offer as long as the patient is appropriate, because if we can help manage the weight in addition to medication and lifestyle, that also helps. And the last thing, which we should always consider as a access opportunity in care, is research. Given that we do not have an opportunity right now to treat fatty liver disease with a specific medication, we are looking at a lot of contenders in the research industry that help to remove fat in the liver, maybe decrease inflammation overall. Also, another bucket of treatment is reversal of scar and fibrosis. And the last bucket of therapy within the research is decreasing insulin resistance or improving fat metabolism in the liver. So clinical research is definitely part of the care option. And the last thing I'd like to speak on is the prevalence. The prevalence of fatty liver disease, as we know it, is about 25% to 30% throughout the US and the world. But what we also know is that when we look at the various ethnic groups and races, we see that Hispanics have a higher prevalence of fatty liver disease, followed by Asian, whites, and then lastly, Black individuals. Some literature would support that NAFLD and NASH only exist in about 3%, 5% of Black individuals, which may be an underestimation and definitely something that we need to unpack further.
Well, thank you for this incredible overview. Thank you, Dr. Gunn, for this incredible overview. And I didn't mean to interrupt you, but I'm just really, I have to interrupt here just a moment, because, and maybe this is your experience too, I often hear in clinic from my patients who are referred, I have a general hepatology practice, that patients are coming to me with fatty liver disease and they're being told there's nothing we can do. And I'm just really struck, honestly, to see all of this on one slide, that there is so much that can be done, lifestyle, medication, surgery, to really manage the underlying causes of fatty liver disease and NASH, and even clinical trial participation. So I just wanted to amplify that this is a condition that is treatable, is the message that I'm hearing here. And you, please continue.
Sure. Let's advance to the next slide, because when we talk about NASH and potentially the disparities, I guess this was a question that you wanted to ask me, Dr. Carr. Where are the Black patients with non-alcoholic fatty liver disease and NASH? Where are they? How come they're not showing up in our clinics? We treat hundreds of patients with fatty liver disease, yet for some reason, the literature will suggest that they don't exist, that they're maybe a couple would have fatty liver that are Black. But we do know that fatty liver disease is the most common chronic liver disease in the US today. But the prevalence seems to be lowest among Black patients. Why is that? We know that Black and white individuals have similar presenting risk factors for fatty liver disease and NASH. Some literature suggests that when Black people do develop NAFLD or fatty liver disease, that they're less likely to progress to NASH. But one other issue is that when they do progress to NASH, they often are the worst of them all. Their outcomes sometimes are worse. Their all-cause mortality, according to Unasi and colleagues, who's an expert in some of the data around NASH, would tell you that mortality rates are higher. Black individuals have less access to transplantation. They're less likely to be treated when the disease is far more advanced. And also, we find in the literature that Black patients die at a significantly higher rate than white individuals with similar disease. What I want to call your attention to, and I'm not sure if it portrays really well on the slide, is the table there that shows you a study. It's the Flint study. This is one of the pioneer trials in fatty liver disease. Back when I was in training, back in 2015 or so, this was the study that many would reference for NASH. It was looking at obeticholic acid for the treatment of non-alcoholic steatohepatitis. As you know, obeticholic acid did not receive a approval for treatment of fatty liver disease, but all that to say, if you look at the table here, there were about 280 patients invited to this study to look at obeticholic acid compared to placebo. And when you look at the white individuals, they made up close to 90% of the population. The Black individuals, on the other hand, were less than 7% total. And this is unfortunately not the exception, it's the rule. When you look at studies that looked at even semaglutide, a drug that is very popular, especially in weight loss and diabetes, there was a recent study that was just published looking at cirrhosis in that drug. They took 71 individuals and looked at them. 2 of them were Black. So are the Black people really less likely to have fatty liver disease? Are we underestimating them? Are we not finding them? And the other thing I'd like to bring to attention here, and maybe some of you can discuss this further, is if we're finding fatty liver in Black individuals at a lower rate, but when we do find them, they're more advanced, are we really serving them in the clinical trial industry? Because if you look at the hundreds of trials that are going on right now for fatty liver disease, very few of them are for cirrhosis and for advanced disease. They're mostly intermediate disease. So we may be missing a lot of opportunity to help our patients if we're only focused on the earlier stages of the disease. So another point to mention is it genetics? Some of the literature will suggest, yes, that Black people have less of the PNPLA3 gene or less of the TM6SF2 gene that we know is associated with fatty liver disease. But again, I think we're missing a lot and we're maybe underestimating the prevalence of this disease in Black people. And I don't want to take anything away from the other speakers, but one last thing I do want to mention, and maybe we can comment on it later, is that one thing that is associated with advanced fibrosis is chronic kidney disease. Black individuals make up 13% of the United States population, yet they make up 35% of those on dialysis for kidney disease. One thing that goes hand in hand with advanced fibrosis and NASH is chronic kidney disease. So could we be missing a whole population of Black individuals because we're not looking for them in the right place? And I'll leave it there to our colleagues and our patient representative.
That is, wow, that's more than a mouthful, Dr. Gunn. So much to unpack there. It is my question, and it's in large part why we all collaborated today to come together to talk about this, because many of us are, we're in these clinical practices and in your research institute, and we're not seeing them. at the levels that we would expect, even with the prevalence data that are available. So I love these hypotheses that you've generated, and maybe we do need to expand where we're starting to look for these patients. We'll get to talk a little bit more at the end and bring everyone in. At this moment, I think I'm going to bring in Mrs. RC, because I know that this is in part your story. You know this journey better than any of us here because you're living it. And again, just thank you so much for sharing your time with us today and educating the public about this condition. And hopefully it's an opportunity for you to learn more as well. Your story is the most important part of the conversation today. I just want to emphasize that. So let's hear about how you were diagnosed with NASH. Can you tell us a little bit about that?
It was some years back. My primary care doctor had got some blood work back and investigated a little further, and that's how it was discovered. And so they did some extra testing. I can't exactly remember which one it was, but they did extra testing to confirm it, and that's how it was discovered and how it was introduced to me.
And so were you having any particular symptoms back then that you remember? Or was it just kind of a routine checkup?
It was actually a routine checkup. I had no symptoms whatsoever, so it was just kind of stumbled upon, if you will.
Mm-hmm. That's super common that we stumble across this diagnosis. We're thinking about other things, and then we
Right.
happen to find it. So some years ago, can you approximate 5 years ago, 10 years ago? How long ago would you estimate?
I want to say 5 or 6 years ago.
5 or 6 years ago.
Mm-hmm.
And what did your doctor tell you at that time to do for your condition? What was the advice that you were given?
If I'm being honest, it was a very vague. First of all, they weren't. He was kind of like he wasn't concerned about it. That it was there. Just kind of like, well, lose weight or change your diet, but nothing specific. The general thing that I got from him was that lots of people have it. It happens all the time. I'm not concerned. Change your diet. Not what to change it. It was kind of like to promote weight loss, but nothing specific at all.
So no specific diet, any specific medications were recommended at that time?
No.
Were you sent to a liver specialist, a hepatologist?
No.
Have you ever seen a hepatologist to this day?
Never.
How about were you ever asked to participate in a clinical trial specifically for NASH or fatty
No.
liver disease?
Not at all.
But I do understand that you ultimately did engage in a clinical trial. Can you tell us about that?
It was for weight loss. I was doing weight loss in surgery, and then that's how I ran into the other study or the other trial. What do you want to know about it?
Well, I want to hear, so this was a trial. It sounds like it wasn't for liver disease. It was for weight loss. And can you tell us what you can about who approached you and what that conversation was like?
Well, I'm going to be honest with you. I see a lot of doctors, but I do remember that whoever was explaining everything to me was just saying what was going to be needed and the importance of it, and comparing the results before or after the weight loss surgery to kind of get a better look at it as in general. And so I wanted to be a part of it, because if I can bring awareness to something, that is awesome.
And what made you say yes, besides just wanting to bring awareness or help research? What else was going on that you felt you wanted to choose this for yourself?
how do you mean?
Well, sometimes people participate in clinical trials for different reasons. Were you experiencing any other health conditions that you maybe wanted to do something different, or were there
Well,
other? Mhm.
I'm sorry. Well, go ahead. Finish what we're saying.
No, that's okay. You go.
Yes. As I was on a journey to change my entire, like, everything about my health, or turn it around. I'm only 39, so I'm already young. And when I started to um, uh, come across different um, health problems, I was fairly young, and it was just one thing piling up after another, one thing after another, and it snowballed into it. I mean, like, high blood pressure and diabetes, different, just a lot of different things, a lot of different diagnoses. And so I wanted to know more about me, about what was going on with me, what things to look forward to in the future, what things to, how to look at things differently. So, and as much information that I can get about how to do that, that's definitely what I would want to do. Which is why I had the surgery, and we're trying to get pregnant. But I'm just trying to really have like a overall health turnaround for me.
And what was that surgery that you had as part of the trial?
I had the bariatric surgery.
How are you doing? How was it? Was it successful?
Yes, I have lost 120 pounds, and I I was used to it. Became normal for me to kind of uh, go to the doctor, and the wait like whenever they would take blood work for something else, it would be like there's always something wrong. But I kind of look forward to it being, oh well, it's less than last time or something like that. But this is the first time. I just actually in August I had a full complete blood workup, and everything is normal, everything is good. And so it's keeping it off, and it's a whole entire lifestyle change, and being able to do things that I have never been able to do, and just really changing. It changed my life so much for the better.
That is amazing. I'm so thrilled to hear that that's your story. And I wish everyone could have had such fortune as you to have been approached by someone who maybe could help at a time when it sounds like you had a lot going on medically. Even though you didn't do this for liver disease, I mean, we're going to get back to that because that's what we're talking about. But this whole time, no one was talking about your liver. It sounds like it was
At all.
other things. Yeah.
Right. Like it was. I don't know if it was just because it was like whack-a-mole. It was like, I had heart issue and blood pressure and diabetes, a lot of the different things that some of the other people before me were talking about that they seen, like, but it just wasn't talked about. It wasn't, I'd never, no one ever addressed it or talked about it. Once again, I'm not blaming anyone, because you got to take it, you got to know, but no one really addressed it or talked about it. And so it's needed.
Yeah. When was the first time you actually heard the term NASH?
Saturday,
Right,
that was the first time I
right.
hadn't heard it at all.
As part of your surgery and the trial, I understand that there was a sample of your liver taken. Is that
Yeah.
accurate? Yeah. And, you're contacted with those results, and it's literally Saturday, just several days ago.
Yeah, that's the first time.
Yeah.
And that's scary to know,
Yeah.
you know.
I can only imagine. Well, you're here now and you're learning a lot today, and thank you for sharing your story, because we're really trying to just help more people, right? Learn. If you don't know, you don't know how to help yourself. And what
Right.
I'm hearing from you is that no one had to, provide you with a gimmick to participate in a clinical trial.
No.
you really just wanted to help yourself, help your health, and help the cause of research, which is, you know, incredible,
Yeah,
incredible that you
and
did.
if I mean, I I'm sorry, I'm over. I'm like I overcame come with emotion, but it's just this entire thing. I'm just so happy to be a part of this, and I don't think of things as like by chance. Just by chance. Something happens, but it can be life altering. And just since Saturday, just getting the information, what you guys do is so important. So I'm just so happy to be a part of it, and just be moving forward. And thank you guys so much for all that you do on a daily. I mean, it's been since Saturday for me, and I'm like, wow. I was just watching the thing. I put on my glasses because it's like, if people knew this information, it's like, what would they do? If they just knew this information. So it's just important. So I'm gonna stop there.
Well, you don't have to stop, but we're going to come back to you too. And I agree. Knowledge is power. I mean, it's really so powerful. So are you going to get a liver doctor after all of this?
Yes. Right away. I definitely am. And I don't want to scare a lot of people, but I'm telling everybody else I know, like, "Hey, you been checked out today.
Well, I'm happy to hear that and really pleased at the outcome since your surgery. Dr. Gunn, I'm going to bring you back in now. So many questions. I have so many things. So we don't have a lot of time, but does this story resonate with you?
Absolutely. And I just want to say thank you, Ms. Arce, for not only being on the panel with us, but also for your heroism in being a clinical research participant. And I hope that you can advocate for research, especially in the Black community, to represent us in the trials and be more an advocate for us, so we can know that when these medications are someday approved, that they're going to work universally in everyone. And even the diagnostics that we're using to identify and diagnose NASH, are they equally as good in those that are Black? And we won't know that without people like you. So thank you so much.
Yes, what she said. We have to move on. Wow, Miss Arce, that's the word. Dr. Pickett Blakely, I'm going to bring you in now. I'm really frustrated, I have to say, when I'm in clinic and even outside of clinic, when I hear this, what I view as a very misleading narrative that we can't do anything for NASH or fatty liver disease more broadly. Do you agree with this narrative?
I actually do not. Nothing could be further from the truth. And hopefully you'll give me the opportunity to discuss some of the therapeutic options that we have. Although there may not be FDA approved drugs, we do have therapeutic options available for patients with fatty liver disease and NASH.
Let's hear about those. And I think maybe just the non-surgical options, if you can focus on those.
So every chance I get, I am so happy to talk about lifestyle modifications, because the fantastic thing about lifestyle modifications is that it can help NASH, it can help blood pressure, it can help diabetes. And we know that in patients who have other conditions like high blood pressure, diabetes specifically, up to 80% of those patients actually have concomitant fatty liver disease. So with modifying one's life, enacting healthy lifestyle practices, you can not only treat your underlying NASH, but you can help lower your blood pressure. You can help improve your blood sugars. You can help your overall quality of life. And here in this slide, the 4 main tenets of lifestyle modifications that are actually foundational for the management of fatty liver disease and NASH are listed here. Mainly, we start with healthy diet. Now, the question I'm always asked is, which diet is the best diet? And the short answer to that is whatever diet you can stick to. We have studies that look at changing your diet from high fat to low fat, to high protein diets, to low sugar or low carbohydrate diets. But we know that the diet that an individual can stick with is the diet that is most likely to exert long-term sustained benefits as far as weight loss goes. When you talk about specifically patients with NASH, there aren't a lot of studies looking at specific diet interventions, but if we extrapolate from some of the studies that we are aware of, for example, some studies looking at diets like the Mediterranean diet, which we know has anti-inflammatory properties or properties to lower inflammation in the body. We know that diets such as the Mediterranean diet are most likely to be helpful in patients with NASH. In addition to that, general lifestyle practices where you increase the amount of fruits and vegetables in the diet, where you increase the or reduce the amount of processed food, where you reduce the amount of sugar sweetened beverages, your sodas, your fruit juices in the diet, those can be incredibly effective. In addition to that, physical activity and diet go hand in hand, but I have to be honest, when you're trying to lose weight, it's about 80% diet and the rest is physical activity. But physical inactivity and healthy diet go hand in hand. They're synergistic in terms of improvement as far as your weight loss. So the question is always how much physical activity is necessary. So physical activity, the interesting thing is from a lot of the studies in the 1980s, we pulled away from the cardiologist that is 30 minutes a day, most days of the week, that helps one lose weight. And that is actually good when it comes to cardiovascular or your heart health. But when you're talking about losing weight, you really need to create, if you think about your checkbook, you need to create a deficit or you need to overdraw in order to lose weight. So when it comes to physical activity and diet, you actually need to induce a negative amount of energy. So you need to work off more energy than you take in. So we actually have studies that show that losing that more than 30 minutes a day actually is what pushes the needle towards weight loss. In addition to that, there are some really, really interesting tricks that you can do. We know that you get the most benefit from going from no physical activity to some physical activity. We know that you get greater benefit with using larger muscle groups. So if for example, using muscles in your thighs and muscles in your core or your trunk, that actually gets you more muscular burn. And then the other thing that I think a lot of people think about physical activity and they think, oh, I have to go run a marathon or run around the track or get on the treadmill. One of the most underutilized forms of physical activity is actually strength training. So we know that exercising your muscles and building muscle, when you compare muscle tissue to fat tissue, is much more metabolically active. And when you think about what you need in terms of going back to creating that deficit is building muscle, because the muscle can actually help work for you in terms of increasing your energy burn. So physical activity is incredibly important. Sleep hygiene and stress reduction are two of the most underappreciated aspects of lifestyle modifications that are really absolutely critical to weight loss. We know that abnormal sleep cycles are linked to weight gain and excess body weight or obesity. And there have been studies looking at the fact that deprivation of sleep causes one to increase their energy intake over the course of time. One can also, you often seek out calorie dense or foods that actually have more calories in them. So sleep hygiene is extremely important. We know that some of our patients who are affected by obesity also have something called sleep apnea. So the sleep that you do get when you have sleep apnea is actually ineffective sleep, and that can compromise your overall body's metabolism. And then lastly, in terms of stress reduction, we know that in states of excess body weight or obesity, there is increase in stress-related hormones. So we all know that we live with daily levels of stress, but that increase in stress has an effect or has an impact on the type of foods that you choose, the type of diet that you pursue. And so having all of these factors in your life adjusted for the better can actually help you. So the question is, how much weight loss is too much weight, is enough weight loss to help your liver? We know that with healthy diet, physical activity, helping your sleep and stress reduction, over the course of time, you can get about 5% of your weight loss. And the challenge with that is sustainable. The problem with just modifying your lifestyle is that life happens and Sometimes you sustain an injury, you're unable to exercise. You may have a medical illness that compromises your ability to stick with the diet, etc. So we know that sticking to lifestyle modifications over the long term, many times you will see weight loss, but unfortunately the weight can come back. So with the advent of newer medications and some other procedures and interventions, they can be helpful to help us sustain the weight loss. So I mentioned just that with lifestyle modifications, you can get up to 5% weight loss, but the target is 5 to 10% weight loss. So what can we do to sort of push the needle to give us a little bit more of a boost? And if we look at our next slide, we can look at sort of the next tier or the next level of additional treatments that we use. If we look at any other condition like high blood pressure, diabetes, in not too many instances are we expected to completely cure or treat the disease with one intervention. And weight loss and NASH should be looked at in a similar manner. We have lifestyle modifications that are foundational, and then we look for additional treatments that can augment the effect of the lifestyle modifications that we're using. And here on the left of the slide are anti-obesity medications. So it's an extremely exciting time to be in this field because after decades of sort of a drought of weight loss medication or weight loss medications that come onto the market and then are withdrawn, we now have 8 FDA-approved medications that are anti-obesity medications. And although none of them are yet approved specifically for NASH, we do have evidence from research that has been done in animals as well as research done in human beings that specific classes of medications not only help patients lose weight, but also have an effect on some of the mechanisms that Dr. Gunn mentioned before, specifically with respect to the insulin resistance or the liver's response to insulin, as well as the response to insulin in the rest of the body. And specifically 2 medications that are FDA approved for weight loss, liraglutide, which is Saxenda for weight loss, and semaglutide or Wegovy for weight loss. Those have been shown in clinical trials to positively help the density of liver fat as well as the inflammation in the liver. And then lastly, bariatric endoscopic procedures have been, well, one specific procedure has been approved by the FDA for weight loss. And these interventions, although are not specifically approved for NASH, and we're accumulating on a weekly and monthly basis evidence that these interventions can also improve patients with NASH in terms of what the burden of fat in the liver is, and also the blood test for showing inflammation in the liver. The picture on the left has the Orbera. This is actually a balloon that is placed using an endoscope. So if you've ever had a colonoscopy, this is a sort of colonoscopy in reverse. This places a balloon in the stomach and serves to help one remain full in between meals and achieve fullness during meals. The placement of the balloon is temporary and is removed after 6 months. And then there's a procedure that is gaining a lot more traction and popularity called the sleeve gastroplasty, where compared to the sleeve gastrectomy, which we're going to hear about a little later, this is a procedure where the stomach is made into a smaller compartment using a device that places either sutures or staples in the stomach. So the bariatric endoscopic procedures can move the needle. So we talked about with lifestyle modification up to 5%. Anti-obesity medicine can get you 5 to 10% weight loss, but with the newer agents that we have on the market, they're sort of pushing more of the 10 to 15% of weight loss. And then when you add bariatric endoscopic procedures, we're seeing up to 20% weight loss. And then I'm sure we'll hear about bariatric surgery, which is the gold standard, which can get you 30% body weight loss and even higher than that.
Thank you, Dr. Pickett-Blakely. Wow, there's so many options for people who have NASH, and we have actually a lot of treatments available today. And were available yesterday and the year before that. Yet there's so many who go untreated or are told that there are no treatments to help their liver condition. Why do you think it's been so hard to get this message out to providers that, fatty liver, okay, we don't have a new FDA approved medication specifically for liver disease, but we have other options, additional options that are really effective and important, because our patients don't just come to us with liver disease, right? They have a lot of metabolic issues. What do you think it's going to take to kind of change that narrative?
Yeah, I think that we have to go back to viewing patients holistically. An individual patient is not their NASH, it's just not their obesity. We have to look at these conditions as a continuum of a metabolic disorder. So again, I'll say there's usually high blood pressure, and I think Ms. RC spoke to this. There's high blood pressure, there's, if not diabetes, pre-diabetes, there's a little arthritis, there's some sleep apnea. And so if you think about the patient as a whole, and I just want to speak briefly to what Ms. RC said about not hearing about the interventions. I think for any of us who are here, if you've tried any change in your behavior, you know how difficult it is. And I think one of the barriers that we face is just how difficult losing weight and lifestyle modifications are. But if we think about it as a marathon and not a sprint, and how each and every modification that we make, if you add them up in sum total, they do help. I think that sort of helps us chip away at the mountain that seems to be in front of us.
So I'm going to put you on the spot a little bit. Dr. Gunn got us started. You see a lot of patients with obesity. I have a hepatology practice. I ask myself this question often. What percentage of patients in your practice are Black? And does that percentage match what you think it should be?
Yeah, that's a good question. I think, notwithstanding your geographic location and all of those things, I think, one of the reasons why I was prompted to get involved in health disparities research is when I was in training, I would see patients in the hospital, specifically with bariatric surgery complications. And I noticed that population didn't match the population of individuals that I was just seeing out on the street, on the streets of Baltimore. And so I think, you're absolutely right. I think at this point, my practice has matured a bit. And so I'm seeing, many more patients of color that I'm treating, but relatively speaking, there is not great alignment between the patients who are affected and the patients that are seeking therapy.
Thanks for letting me put you on the spot.
No numbers.
Dr. Wilson, I'm going to bring you in now. I think it's a really, really good point, because we've now heard about medical therapies and endoscopic non-surgical therapies. Can you tell us what's available surgically for individuals with NASH, and specifically, what is bariatric surgery?
Yeah, absolutely. And thanks again for having me, and honored to be part of the panel with the esteemed guests. But yeah, bariatric surgery, it's also known as weight loss surgery. And we're really pushing the term metabolic surgery now, because we know that it has not just weight loss impact, but metabolic impact. So it refers to surgeries that induce weight loss and impact metabolism by altering the gastrointestinal system and the anatomy. And so for those who are appropriate for the procedure, it can offer significant and sustained weight loss in the long term. And it's one of the most effective treatments for obesity and obesity-related conditions, including NASH. And as you can see on the slide, the sleeve gastrectomy is by far the simplest, we say, of the weight loss procedures. And it offers about a 25 to 30% weight loss, at least for individuals. And so, and that's a higher impact or higher weight loss effect than our traditional or conventional treatments for weight loss. And one thing we try to emphasize is it is covered by many major insurances. most major insurances offer coverage. So some people think that there's a barrier to weight loss surgery, and it's not as big a barrier as one may think. And so the endoscopic procedures that were mentioned earlier, a lot of those are self-pay, and so not very accessible to patients with NASH in the Black communities. And also medications are certainly limited to a time frame that you can take them, or you have to have diabetes for some of the GLP-1, some of the more effective and newer medications. So bariatric surgery is impactful for more than just weight loss, and we're really excited about that.
So can you describe to us what, I think you're gonna show us now. What is it? What are you doing when you operate?
So this is the animation is of the sleeve gastrectomy, and so we remove 80% of the stomach and we take it out of the body. And so individuals are left, you kind of go from having a balloon shaped stomach to a banana. And that portion of the stomach that we remove, it makes hunger hormones. It's metabolically active. So hormones like ghrelin made and kind of controlled in the fundus. So we take that away. So I tell patients your appetite changes as well as your capacity to eat and drink. Oftentimes we have a set point and we're fighting physiology and biology to lose weight. And it's not all behavior. Much of it is. A lot of this is a genetic component. And with time, hormone changes, age, you have a set point, and weight loss surgery can really reset that point, and you really get a long-term sustaining of weight loss. But this is the sleeve gastrectomy, the most common weight loss procedure worldwide and in the United States.
Thank you. Now, you see a lot of patients with obesity, obviously, in your practice. Are you seeing a significant amount of Black individuals, like more than what, or about what you might expect to see given the metabolic risk profile of our community?
You know, I do feel like I'm seeing more kind of these days than maybe I did kind of coming up in my training. So if I could give a number to it, I know we didn't give numbers earlier, but maybe in my practice, 20 to 30% potentially. I mean, I'm in Cleveland, so there's it's a geographic location too. But yeah, I think I am seeing a good number, and they're not coming necessarily because of NASH, but they're coming for their obesity, and I think that's really important. But we know NASH shows up is like the hepatic manifestation of obesity in the liver, and so a lot of the patients show up really silently. They're coming for general obesity. Hey, I just want to be healthier. And we end up finding out, hey, you also may have NASH too.
How do you find out that they might have NASH?
A typical scenario is some people may come in with really no evidence of it, but we'll do a routine blood test, including like a CMP, LFTs, and some people have elevations, even the slightest elevations in their LFTs. And we do routine ultrasounds to look at the liver and the gallbladder for our patients as they go through the program. And we're often really overwhelmingly finding fatty changes in the liver. But we know that the gold standard for diagnosis is a liver biopsy, which of course is not as accessible. It's invasive. And so, but at least having your blood work, your routine ultrasounds, kind of low profile testing is really a start that I think we can pay attention to, and that can clue us in to investigate further.
So the liver function tests, the LFTs might be the first sign, but what I'm also understanding is in your practice, you get an ultrasound on everyone, and that's how you're finding it. So thanks for sharing that. I read a really great article that you co-authored recently, and I was hoping you could tell us a little bit about that, bariatric surgery in patients with NASH.
Absolutely. I was privileged to be a part of the study that we published in JAMA called the Splendor study, and that stands for Surgical Procedures and Long-Term Effectiveness in NASH Disease and Obesity Risk. It was hard to come up with that acronym, but we did it. But we looked at like 1,158 patients who had both obesity and NASH disease. And a little more than half of those individuals, and again, this is biopsy proven NASH disease, not just maybe some clinical labs that were off, biopsy proven NASH disease without cirrhosis. So out of the 1,150 patients, a little more than half underwent the two most common weight loss procedures. So either a Roux-en-Y gastric bypass or a sleeve gastrectomy. The remaining 500 or so patients underwent usual care, either lifestyle changes, medications. We lumped them together. And so we found that over time, a 7 to 10 year span, actually, those who underwent metabolic surgery had an 88% lower risk of a major adverse liver outcome. So that means developing cirrhosis, developing liver cancer, needing a liver transplant, and even death. So those major adverse liver outcomes were significantly reduced in the population of patients who underwent surgery, and Blacks were about 9% of the surgical group and 4% of the non-surgical group.
That's pretty impactful. Thanks for sharing those highlights, and I encourage everyone to read that article, because what I'm hearing here is not only do we have medical therapies, we have clinical trial participation, we have GI endoscopic procedures, we also have surgical procedures that can treat NASH today and treated NASH yesterday. So there are indeed therapies for patients that are available. You must have everyone knocking on your door for these surgeries, given what you just highlighted.
Well, unfortunately, not. We really only treat 1 to 2% of individuals who would qualify for metabolic surgery. And it's mainly due to a stigma of needing intervention for obesity, which is, of course, an epidemic, a chronic disease that really needs treatment, and lack of awareness that many insurance providers, again, actually do cover these surgeries. And really based on our data, the strong data that we're getting. And I didn't mention that in that study, we found the same thing for heart disease, major cardiovascular events like a heart attack, stroke. Patients who underwent weight loss surgery in that study were 70% less likely to have a major adverse cardiac event. And then we were able to take it even further and prove by biopsy again that NASH can also improve or resolve in some of these patients, 69% versus 23%.
1 to 2% of all who qualify are seeing you in your practice, and the majority of those we know are going to have fatty liver disease and probably NASH. We're not seeing a lot of Black individuals in clinical trials. We're not seeing many of them get access to these medications. I'm not seeing many of them in my general hepatology clinic. And so, Dr. Wilder, you must be seeing a lot of these patients. Dr. Wilder, you're a transplant hepatologist, and that makes me very worried, because if we're not seeing them at these earlier stages, they must be running down your clinic. Is that the case?
Sadly to say, unfortunately, that is not the case. As many of you know, we have an issue with respect to access to liver transplantation across the board, right? In that particularly Black people are significantly less likely to be referred for transplantation. And even if they get referred, to successfully navigate the process to actually being listed for a liver transplant and receiving it. And I'm afraid when it comes to NASH, the underlying issues, right? Those fundamental causes of health disparities that impact outcomes in so many other areas of health probably come into play here. There's a lot for us to learn in terms of understanding the numbers to truly understand the disparity with respect to how we all fall in terms of the burden of fatty liver disease and how that varies by race and ethnicity. But unfortunately, when it comes to transplantation, we just are not seeing the referrals as we'd like to.
So where are they? Where do you think they are? I mean, are they just not getting advanced disease, you think? Or you think it's a disparities issue, an access issue? What's happening?
Yeah, it's probably a Venn diagram of all the things you just said. It's probably a combination of access, i.e., are they in places where people are recognizing that they even have NASH? And Mrs. Archie spoke to that already. And then, are those providers appropriately referring them to a hepatologist? And then is the hepatologist or specialist they're seeing a person who is not biased and will appropriately refer for transplantation if necessary? And then once they get to the transplant clinic, will they be able to, in that next step, successfully navigate that process of getting to the clinic and then the process of going through the evaluation? And unfortunately, every time we add a step in any process, particularly when it comes to Black folks, is an opportunity for things like racism, structural racism, and bias to lead to people being leaked out of that process, lost in that flow, and then exacerbating health disparities.
So you're the expert here in health disparities. What do you recommend that we do?
I think there are a number of things to consider. Without question, I think we need to leverage individuals like we have here on this panel. Think about the work that Dr. Pickett Blakely's doing, that Dr. Wilson's doing, that Dr. Gunn is doing. They have the expertise. Putting them in a spot like this, quite frankly, taking them and the work they do to the communities of color, particularly Black communities, so people are aware of the resources that are available to them and aware, quite frankly, of the existence of NASH, as our patient, Mrs. Archie, spoke to already. But I think along with that comes the importance of ensuring that we have the resources available, not only educational resources, but policies to support access to those new medications when they come out, access to appropriate surgeries if need be. If you're not signed up for Medicaid, which will cover some of these things, helping people get signed up for Medicaid, and having the resources to help people navigate those issues. Addressing those sort of structural barriers that historically have driven disparities in many spaces will be important as we think about how we can address NASH within the Black community.
Are we missing anyone here at the table? Dr. Wilder?
Yeah, we are definitely missing policy people. We are constantly hearing about potential groundbreaking medications coming out, but they're only going to be helpful, if people can afford those medications, if they're covered by the right insurers, and if we don't have absurd requirements before a person can gain access to it. And the example that comes to mind for me is like hepatitis C, where you remember when hepatitis C came out, you had to have really, really advanced scar on your liver. You had to be so sick before you got it. It was so expensive that it exacerbated disparities in terms of hepatitis C. And Black folks were the worst ones in terms of being impacted by hepatitis C. And so I'm afraid that when it comes to NASH, we have to be careful with the policy and how we implement these new medications or any kind of new technologies within the space to ensure that access is there, coverage is there, and that any sort of requirements on access to these new treatments has got to be reasonable in terms of how we move forward in that space.
Dr. Gunn, we're talking solutions now. What about the clinical trial space? What do you recommend needs to be done to solve this access issue?
I think a lot of it has to do with the community, again, of providers that look like the people we're serving, to get into the motivating people of color to be part of clinical trials, to show them examples where medications did not work in particular ethnic groups and racial disparities within medications that are even approved today, when you look back, didn't work. And Dr. Wilder even mentioned hepatitis C. Do you remember, if you were Black, you wouldn't get a percentage point of cure? So I think that we have a lot of work to do to get out there and spread the message to the community. And we cannot stand for clinical trials that don't represent us. As you know, the FDA with the DEPICT Act in 2022 was advocating that these sponsors, these trial pharmaceutical companies, need to have a diversity plan, and it needs to show that it's doing something to raise the bar. So I think we just need to be very, very intentional.
Absolutely. Doctors Pickett, Blakely, and Wilson, give me your bullet points. The medical and surgical fronts, what do we need to do?
NASH is everybody's disease. It's not just a hepatologist disease. It's not just a gastroenterologist disease. It's all of our disease, because we know it's on the spectrum of metabolic disease. And I think if we start there, we need all hands on deck. We have over 76 million people in the U.S. affected by obesity, but we can't just have one gastroenterologist out of 47 that treats obesity. We can't just have, one person receiving all the referrals. We need all hands on deck. And I think we have to put everything in context. You know, we treat a lot of complex conditions, we treat a lot of complex disease, but focusing on lifestyle management and counseling our patients, not just saying lose weight, but giving people the tools and how to do it is absolutely essential. So we need everyone involved at every level.
Dr. Wilson?
Yeah, I really agree. And really, in addition to education, we need to be intentional as providers, educating, the public and our colleagues. And, where are the patients with NASH? Obesity and NASH go hand in hand. So they are likely oftentimes those who have obesity. And so the worst thing is when I have to evaluate patients for weight loss surgery so they can qualify for a liver transplant, because this is how late it's been. And so that's oftentimes where I do see the end stage of this disease. So it's really being intentional, partnership, education. And I think if we are looking for it and are aware, we'll find more. And but I think we can all be encouraged that there are treatments and opportunities to improve the awareness and early treatment for NASH.
Thank you. Ms. Arce, you get the last word. What do you think we can do better as a medical community from a patient perspective?
Man, exactly what you're doing right now. I as a community, just this little piece of information, just this little tiny, well, not tiny, but this panel, just this piece is just it's like a moving, like for me, it's like waves of wow, just letting people know. And so I really couldn't answer you as to what one thing that you could do, but it does have to start somewhere. And it's like armor for me. That's what it's like. It's like armor. If I don't know to arm myself, if I were to go, I wouldn't have came across the study or been fortunate to be a part of this, I would have really thought of it as, oh, well, there's lots of people that have this, and all I got to do is lose a little bit of weight, and it should have been good, and never have it be addressed. Or if it wasn't something that was addressed to as far as the Black people or your race or putting it to those different things, you wouldn't be able to have that armor or to be fully equipped. So equipping the people and it is what you would have to do. And everything that you guys have said here, I really wish that I could force people to watch this. You can't, though. All you can do is do what you can do. So I'm going to do my part. I mean, I do have a huge mouth, so that's all you could do is tell someone. And I'm so full. I really want my family. I feel sorry for them, but it is what it is. I'm going to be preaching it, and that's what you can do is to give the information. Because if I don't know you personally, it's one thing if I'm in Seattle or if I'm somewhere else and I'm telling you, but for me to tell someone that I love my story, they could hear it from anyone else, but when you hear it from someone you love, it definitely is a lot more impactful. And I just, that's what I would think, is to start somewhere. And so that's what I'm going to do. So
I love that. Perfect. Start somewhere, and knowledge is armor. I think I'm going to steal that. I think that's a perfect analogy. And with that, I mean, we could really go on talking for much longer, but I'm going to bring this panel to a close. Thank you to everyone for participating today, especially to Ms. Arce, our patient advocate and patient herself, and all of our professionals here who really lent your expertise to this conversation. We will get to work to level the playing field to ensure that Black patients have access to all of the current and future NASH therapies. And when we do this work, by the way, for Black communities, everyone will benefit. For those watching, we're asking you to really just reach out to your providers to ensure you're discussing all of the treatment options for this condition. And to find out more about our organization, ABGH, you can find us at blackandgastro.org or on social media at Black and Gastro. And this recording will be available very soon on our website. Thanks, everyone.